So again, I'm going to talk about managing medications and side effects, and I'm going to go back a little bit, like even before like we choose medications and all of that, and then I'll get to some of the medication side effects and things to think about. I think that this could be a 24-hour talk if we get into each medication in detail. Obviously, we are not going to do that. So I tried it, like I said, I tried to make it like shorter and sweet, and I'll just be talking a lot about different things, but so we're going to review some definitions, review when and how medications are chosen, review different types of medications, common side effects, and then what to do when potential side effects come up. So a seizure, as you all probably know, whether you've heard it from your physician, your provider, or the Epilepsy Foundation, is a sudden change in behavior, or it can just be a sensation that's a result of hypersynchronization of neuronal networks in the cerebral cortex, which is where seizures are generated. So electrical activity that kind of goes wrong. But that's not the same as epilepsy. And that is important because that makes us decide on when to start someone on medications. And epilepsy is having had at least 2 unprovoked seizures occurring more than 24 hours apart. You can also diagnose epilepsy after having 1 unprovoked seizure, and recurrence risk of more than 60%, meaning the reason we use that percentage is because if we have had 2 unprovoked seizures in more than 24 hours and kind of spread apart in time, and we really don't have a reason, they're unprovoked, the chances of having more is greater than 60%, and that's where that number comes from. So if you have 1 unprovoked seizure and something else that also puts you at that higher risk, then we diagnose someone with epilepsy, whether that is because they have an abnormal EEG, because they have, or highly abnormal EEG, or we've captured one of the seizures and we're worried that they could end up having more. They have an abnormal MRI that tells us that this person is at very, very high risk of having seizures, et cetera. Or someone has an epilepsy syndrome diagnosis, which is a diagnosis we made based on different things, but oftentimes it's dependent on age, depending on age of presentation, types of seizures, type of EEG, et cetera, and what medications they respond to. So to treat or not to treat, I think there's a lot of things to take into consideration when we talk about treating epilepsy and treating seizures. And so first is, do you have epilepsy or not? And or have you only had 1 seizure, but we're worried that there may be more seizures in the future? So if you have epilepsy, we often recommend, if you have kind of met those criteria, we then tend to we recommend treatment for a patient. And that may vary from patient to patient. Some families may want to wait a little longer. Some families want to start treatment right away after the first seizure. So I think there's not one treatment for everyone. Everyone is different. And I think that's how we practice. We treat everyone differently because as much as there are guidelines for some things, not everything fits one person. And so I think that this is really important. And these are conversations so depending on the age of the patient, depending on if someone lives alone, the safety, like how big were the seizures, how subtle were they? And we take all these things into account when we are deciding on whether we should treat someone or not. And so medications, up until the mid-1990s, there were only a handful of medications available, but now we have more than 25 different anti-seizure meds available for clinical use, and which is great because it obviously gives us more options to prescribe, more options and more, I feel like more opportunity for the families and patients to decide from like a group of medications, what I'd like to be on, what I'd like to avoid, et cetera, especially when we're dealing with comorbidities and other issues. Up to 60% of patients may respond well to the first or second choice of medication. And then there's about a 30% of patients that are refractory to different medications over time. And often side effects become a little bit more complicated when you're dealing with obviously more than one medication, and let alone if you have comorbidities and there's many more medications involved, all things we also have to take into account. So the goals of treatment, what are they? So ideally for all of us, it's seizure control or seizure freedom. So if we can control seizures altogether, start medications and make them stop entirely, that's what we all want as physicians, as patients, as family members, everything. minimal to no side effects. None of us like side effects, even if they're temporary. Some of them are tolerable, some of them are just not. And that's okay. That's thankfully we have other options, and we can always talk about that and what other options we have or what you can change to. And then obviously quality of life comes with all of that. I think quality of life is one of the most important things we do, and is trying to find what quality of life is for each patient, which again is different. For some people is they want to go back to driving and be independent. For some people is just having less seizures. For some people is I want surgery now. And so this is different for everyone and for every family. And so when we are choosing medications, we also need to understand what the causes of epilepsy are, if we identify them, or if we know the cause of epilepsy. Epilepsy, like I said before, to diagnose epilepsy, those are kind of the three requirements, but epilepsy is kind of an umbrella term for many conditions that cause seizures. And so epilepsy just tells me that someone is at risk of having more seizures in the future and needs medication. So it's a little bit of a big term to describe multiple different diseases that can cause seizures. And so seizure types are also important to consider, because depending on the seizure types a patient may have, we may choose different types of medications. And the frequency is important. There are medications, as you well may know, that start working right away. Within a week or two, you have a good dose. We should know if it works very quickly. And there are other medications that it can take 3 months, 4 months to get to a good level or a good dose of medication. And so if someone is having seizures 4 times a day, we don't have 3 months to wait. We have to start something that acts sooner or acts faster, so that we can get to a better control as fast as possible. Comorbidities, like I said, if someone has liver disease or heart disease or kidney disease, then we may have to switch the medications we're using, or the medications we had in mind for the seizure types may have to be tweaked a little bit, because it may not be appropriate to start someone on a medication that affects your liver if you already have liver disease, for instance. If it's a woman of childbearing age, there are medications that should be avoided as well because of teratogenicity, so they can affect how the baby develops. And so we try to stay away from some medications in those instances. Certain allergies, the types of side effects and what families are willing to accept and what they're not. The ethnicity, so that sometimes depending on ethnicity, you're at higher risk of certain rashes or certain very severe drug reactions and allergies. So that is important as well. The formulation, so there are medications that, for instance, if I'm dealing with a 3-month-old, that does not have a G-tube, and we only have like capsules, or we only have tablets, we may prefer a liquid. And not all medications come in liquid, although most nowadays we can probably make a lot of the compounds. It's not as easy, but some that come in liquid, for instance, need to be given 4 times a day as opposed to twice a day. And so we take that into account, because giving something 4 times a day, if it's hard to remember to take vitamins, let alone like give a medication 4 times a day, can be really tricky. And then the need for labs. I think that sometimes we choose medicines that, if kids are maybe terrified of needles, or that's just very complicated for families to come to the hospital or things like that, we may consider things that don't need a lot of lab checks or monitoring. I touched a little bit upon this, but causes of epilepsy. So this can also affect, like I said, our selection of medications. So you can have vascular reasons, so a vascular malformation in the brain, which may mean that a person needs only a short period of time for medications and have surgery or something like that, and not need medications for the rest of their lives, but also may mean that that person needs to go to the OR, needs to be on medications longer. And there are certain medications, for instance, that we would avoid if someone is going to the OR because of risk of bleeding. So all of these things we take into account when we're thinking. So there's genetic reasons, or metabolism, abnormal metabolism, trauma, infectious, toxins, malformations of cortical development, tumors, autoimmune conditions. And so treatment for autoimmune conditions may be a combination of steroids and autoimmune therapy, along with seizure medications. And in metabolism, it may be that a patient needs some sort of enzyme replacement or something like that. And so we combine all these things and we also have to think about how things interact, and that becomes really important. And obviously there are causes of epilepsy that are unknown to date. So it's not uncommon that we don't find a cause of the epilepsy. And then we sometimes just go by seizure types and all the other things I mentioned before. Whether the seizures are generalized or they're focal. So focal seizures means that they're coming from a particular area of the brain and then spread. And then generalized seizures mean that they're kind of generated kind of everywhere at the same time. And so because of that, these are just a few examples. Obviously, there's many more medications in this, but typical medications for focal seizures are carbamazepine and oxcarbazepine. These are medications that we would never use in a generalized epilepsy because it could actually make things worse. And the opposite may be, it's not always true, but you just, if it doesn't work, you have to think, am I using the right medication, and are we that we make the right decision? So generalized seizures are often treated with valproic acid or ethosuximide. Ethosuximide, for instance, is only used to treat absence seizures. So if you try to treat a focal seizure or a convulsion or anything different than an absence seizure, is just not going to work. So I think that this is another reason it's important to understand what's happening, understand the description of the seizures, and get all the data you need before you make these decisions. And so on to possible side effects. Side effects can be overwhelming because there's a lot out there, and nowadays with Google or Dr. Google, anything can show up. So anything can be a side effect. And even without Google, this is just an example of, in our formulary, this is the list of side effects of a medication that I'm pretty sure everyone here has had in their lives, that it's aspirin. And so really any medication can kill you, that's true. But I think we have to take all these things with a grain of salt. And I think that's why the important communication with physicians is key, because this can be very misleading and it can be very worrisome. And if you are an anxious person and you're looking at this list of medications from like cardiac arrhythmia to dehydration, this says like hemorrhage, this says bronchospasm, fevers, like, and you'd think like, wait a minute, wasn't aspirin used to treat fever sometimes? So I think that coma, confusion, brain edema. So I think that it can be very, very overwhelming to Google side effects of medications. Anything can happen from any medication. And it doesn't mean that, from a lot of medications, I should say, not any, but we have to take that with a grain of salt and look at it in the context of the patient, their comorbidities, their risk factors, and all of that to really understand it. And side effects do not occur to everyone. Some of them are random and they're independent of doses, and some of them can be dose dependent, meaning you may get headaches on a higher dose of a medication that if you go maybe decrease the dose a little bit, you'll feel better. Or you may be on the higher doses of medications that are twice a day, you're too tired and you can't really get through the day through work or school, and we decrease the dose in the morning and we leave the higher dose at night, and all of a sudden you're more awake. And so that could be dose dependent, or it could be related to the time of the day. But all those things we need to consider when we're trying to decide what to do with a certain side effect, especially when we don't want to give up a medication that is actually working. I think ends up being the biggest problem. Like, what do we do when something is working, but it's really not tolerable? And so this is a list of common side effects of most of our anti-seizure drugs. And obviously it's a lot of information, so too much information. And again, I think this can be very overwhelming, but we typically go through some of the most common ones. And whenever we are prescribing a medication, and if your physician is not doing that, you should request it, whether it's because they forgot or they were running late or they're having a busy day or they just totally forgot. I think it's important to address this and ask and answer all the questions before you leave the office, and always, ask whatever you need to ask regarding medications, whether they're new, they're old, and you're noticing things that are new. Common adverse reactions for most of our seizure medications are dizziness, fatigue, blurred vision, sleepiness, appetite changes, and GI discomfort. And this can be it can be dose dependent, like I said, but a lot of times some of these changes we see mostly at the beginning. So in the first few weeks of starting a medication, you may see a lot of this, and these things tend to get better over time for most of our meds. And appetite changes, for instance, can be anything from not eating at all to like eating too much and the patient is gaining too much weight. And GI discomfort can be just discomfort, could be diarrhea, could be constipation. So it's a wide variety of things, and you can get pretty much all of this with any of our medications. And so I think these are all things to keep in mind. But again, these tend to happen at the beginning of the course and tends to get better over time. And what often happens too is that you can, we try to start medications at a low dose or at the lowest dose possible, and then advance as possible. If a patient is having too many seizures, we may start a little quicker. And in those instances, we may see more of these side effects. So sometimes a lot of these are dose dependent as well. So we just tweak things depending on the patient. If we started too high and the patient is dizzy, we may go back down and may get better. And then later on, that doesn't mean that you couldn't try a higher dose again, because it may still feel better once your body gets used to the medication. Right. So also important to watch out for blood dyscrasias, so abnormalities in your blood counts. So some of our medications like carbamazepine and oxcarbazepine and valproic acid can affect your counts. And so some of them can cause low platelets, and some of them can cause low white count or anemia, so which low hemoglobin. And that's why with a lot of our medications, whenever we see you guys, we are to labs, and whether it's once a year or twice a year for some of our medications, we do check serially to make sure that all of this remains normal. In the case of valproic acid and or Depakote, we often see that platelets come down, especially in the setting of illness. But even then, it can recover once the illness is over. So that's something we monitor. And if it doesn't, or if it's been there without an illness and it's too low, we may have to change to a different medication. But it's not, it doesn't happen to everyone. It's hard to predict who it's going to happen to. And we just try to work with it, and depending on whether it's acceptable numbers or not. Rashes. So anything can cause an allergic reaction. I mean, there are patients that are allergic to Benadryl, which should be an allergy medicine. So anything can cause an allergic reaction, but there are several seizure medications, although they can all cause allergic reactions and rashes. There's certain seizure medications like lamotrigine and oxcarbazepine and carbamazepine that can cause severe drug reactions, where you can get a similar rash to this, and it can involve your mouth, your eyes, your entire body, and it can be pretty severe, and a patient has to be seen right away, seen in the hospital. Medications have to be stopped immediately. And someone should be notified. So if some patient, I always tell families, if you don't know what to do, call, because I think there's no wrong in showing up to the hospital, but if you don't know if you should go or you should stay home, it's never wrong to check and ask someone. And the worst that can happen if you end up going to the ER is that they'll tell you everything is fine and you go home. Irritability. Some of our medications can cause mood changes, which I'll go into a little bit later as well. And that's not trivial. It is important, because part of our goal, like I said before, is quality of life. And I think that it's important to understand this. Sometimes, similar to other side effects, we see this at the beginning, and then it gets a little bit better as you get used to the medication. But this one is a tricky one. Irritability or just mood changes. Is it the new diagnosis? Is it everything that's going on in the life? Is it in the last year it's been really hard? Is it COVID? Is it all the stresses of the world? Or is it truly the medication? Or is it the epilepsy itself? And I think that's a little hard to tease out. And that's why we ask for our colleagues or the psychiatry and psychology and everyone to help sometimes to figure out what's what and to understand the cause or the root cause of the problem and really see if it's medication or not, especially if a medication is working. And liver disease, like is something I kind of mentioned before, but some medications can cause liver damage, and we monitor liver enzymes often so that we make sure that that we're not affecting the liver. And so we do, for some of them, it's indicated to do labs even before we start a medicine, because we want to make sure that it wasn't there before. And because if it was there before, is maybe it's not the medicine, and maybe it's something that needs to be checked anyway. And so we need to know the baseline before we start something and decide if it's a medicine that could be causing the problem and what to do about it. And so monitoring, there comes like, we sometimes check blood counts, we check electrolytes. Some of our meds can cause low sodium, and some low sodium is tolerable, but when it's too low, it becomes problematic. Liver enzymes can be elevated. Bone health is important. So we check vitamin D levels in some of our older medications and even some of the more recent ones as well. So phenytoin, phenobarb, oxcarbazepine, carbamazepine, many of these medications cause not abnormal bone health, but your bone health is different because the way your body metabolizes bone is different. And so we need to supplement with vitamin D and calcium to make you stronger. Because especially in bedridden patients or patients that are wheelchair bound that can't exercise as much and can't make their muscles stronger and their legs stronger and their bones stronger, are at higher risk of bone fractures and things like that. So your doctor may be checking vitamin D levels because we need to figure out if you need supplementation. I sometimes just check it anyway, and I find that so many people have low vitamin D levels, even when they're not on seizure medications that cause that affect your bones. And and we live in Chicago, so we don't have that sun all year round. And it may be that we're just not as exposed to the sun, but definitely this is something we often check, and we just say take vitamin D or take multivitamin with to make sure that it has a good dose of vitamin D, et cetera, and calcium. We may also recommend things like EKG when we do monitoring. So some of our medications can change the rhythm of the heart. And so we may check an EKG, like I said before, at baseline, and then a month or two after it's been started to make sure that has not been affected in any way. But equally, there may be a patient that has an arrhythmia at baseline. And so that would be the medications that could potentially cause an abnormal rhythm would never be started in someone that already has an arrhythmia, if it's contraindicated, of course. And so other things that are, like I said before, a little bit hard to tease out sometimes, and our medications cause cognitive slowing. Some of our medications do, not all of them. And again, it doesn't happen to everyone. So some examples of cognitive slowing, you can see for medications like topiramate and Cynicimide. They can cause cognitive slowing, but in patients that don't feel it, they can do just fine. So it's really understanding if it's really a difference or not. And I think that I've had an adolescent once before, after like 2 doses, tell me I'm never trying that again because I couldn't even like read. And so, but then I've had other people saying, I'm doing fine, I'm doing well in school. In fact, I'm doing better because my seizures are better controlled. So I think, again, everyone is different. And I think we have to take everything into account and make sure we're evaluating everything. Mood changes can be real, and from certain medications like, let's say, Keppra or levetiracetam. You can also see mood changes from things like perampanel. Depression, suicidal ideation. Suicidal ideation, most of our medications have like a black box warning that says, and if you go to the FDA, it also says that a lot of anti-seizure medications are known to increase the risk of suicidal ideation by a little bit. But they also note that like it's hard to understand if it's all from the medications, if it's from the underlying condition, or if it's from comorbidities, because many patients with epilepsy have neuropsychiatric comorbidities. And so it's hard to, but it is important to have an ongoing conversation with your physician regarding changes, regarding what's happened, regarding keeping a calendar, kind of understanding the difference before and after, and how person is responding to medications. I think It can be tricky, but if you keep track of it, it may be a little bit easier for the physician and for you to understand what's happened. And sometimes we don't know. And then if we think it's a medicine, we'll just change it to something else. In children, we often try, and I guess in some adults as well, vitamin B6 for children, for patients on levetiracetam, if their moods have been impossible, and it's just hit or miss if it works or not. The data is not that great, but but it can work for some families. And so we at least try it before we give up on the medicine. Rare, very rare side effects, but important that are random side effects. Pancreatitis, which is an inflammation of your pancreas and causes severe abdominal pain and vomiting, and you kind of don't feel like eating. You just have pain and vomiting and need to be seen in the hospital. This is really rare, but it can happen from valproic acid, and it's a contraindication. So once that happens, you can't be on the medicine again. And I'll give you the example. I had a patient that tried like 10 medications, and this is the only thing that controlled him, and unfortunately got pancreatitis. And we had to switch it to something else. And it was really hard later on to control his seizures because this is the thing that worked. And it's unfortunate, but he actually became an adult, and I haven't seen him in a while. But I think these are unfortunate things that happen, but for a long time, the patient was doing fine. So in this case, some of these things can happen really at any time. So pancreatitis can happen at any time. And it doesn't mean that because it happened 5 years after you were on the medicine, it can't be the medicine. So it still should be removed, or you should be seen, and that should be discussed. Aplastic anemia, which means that your bone marrow kind of shuts down and can't produce white blood cells or red blood cells or the different types of cells, and your counts go very, very low. This is really rare and almost never published in children, but it's a reason why people are very cautious with felbamate and prescribing felbamate, and why we check labs very frequently, especially in the first 6 months of life when someone, or 6 months where someone has been on felbamate or started on it. Liver failure. So some of our medications have the potential to cause liver failure, especially, but it is also known that some patients are at higher risk. So there are kids that have, or adults, that if they have a mitochondrial disease, we would stay away from some of these medications because we already know that's more likely to happen. Otherwise, we monitor labs and we make sure that everything stays normal. And if things are normal, then the likelihood of something like that happening it's almost minimal. So if your liver enzymes are normal over and over again, you're probably never going to get liver failure from this medicine, but we keep monitoring to make sure nothing changes over time. Kidney stones, things like topiramate and cynicimide could cause kidney stones. And it's because of the idea that these are medications that cause acidosis in your body. So you then, you're drier, you're dehydrated, you're acidotic, and you can develop kidney stones, and it's all within that list of side effects. You can also cause glaucoma, and we tend to, both for kidney stones and glaucoma, if patients have a history of kidney stones or glaucoma, or there's a strong family history, we may need them, so we may still use them, but with a lot of caution. Drug-drug interactions. So depending on the mechanism of action and metabolism of a drug, some drugs actually work better together. And so they can have a synergistic response, which just means that they help each other to treat the epilepsy even more. And so which is positive. Some can exacerbate the side effects of another medication. So maybe an individual medication doesn't have that many side effects, but when you add it with another one, it increases the side effects of the other medication, whether that is because it increases the levels or just the toxicity of it. Medications can alter levels of other things. So not just other epilepsy medications, but other things. So oral contraceptives is a good example of that. It can make them less or more efficacious. It can, and the other way around. So other medications can cause your drug levels to be affected. And those are all things we also take into account when we are checking levels, when we're checking labs, when we're counseling about what medications to choose and how we should not choose certain medications because of that. So what to do? I think there's not a single answer. So I left this kind of vague because I think there's not a single answer, but I think it depends. If it's a vague symptom, like dizziness or fatigue, like what I talked to in the beginning, I think it's okay to, if you start that medication, you kind of feel a little bit off, let it sit for a little bit and wait, and maybe things will get better. If it's obviously a rash or something that's more severe, you probably need to be seen right away. If it's mood changes, discuss it with your physician. If it's something related to your depression and you don't know if the medicine is making it worse, I think it's super important to talk to your physician and to your different providers about it and decide if that's just not a good choice for you, and if something should be switched. There are times that there are things we can do. So like I mentioned acidosis with topiramate and Cynicimide. So sometimes we start supplements to make that better. If someone has mood changes from the levetiracetam, we may start the vitamin B6 for mood changes. And if that makes it better, then we don't have to change the medicine. So sometimes there are tricks we have to make things better, but sometimes there's not much we can do. And so if it's something that's not tolerable, it may be that the answer is we have to change the medication altogether. But it's impossible to remember all the side effects. So I always say, this is confusing. This is sometimes overwhelming. And so if you have questions, always ask your team, but never stop medications without medical guidance. So there's a reason we start medication slowly, and there's a reason we decrease medication slowly, and stopping unless it's like an emergency, like a drug reaction that's life-threatening. I think stopping a medication without medical guidance, like abruptly, is also dangerous and can take someone into status epilepticus, which is prolonged seizures that may be very difficult to stop. I always like this one size does not fit all. I think many patients would hear from someone or talk to someone that they're trying this other medication that sounds so nice because they don't have any side effects. I want to try that. But not every medication works for everyone. And that person may not have the same epilepsy type that you have, or the same seizure type that you have, or the same comorbidities. And I think it's okay to ask, and it's perfect to ask because that's what we're here for. But it doesn't fit all. And even when the same patients have the same kind of profile, the same clinical presentation, the same seizures, they may not respond the same to the same medication. So I think it's important to keep those things in mind as well, because we just treat everyone individually, like individualized medicine, because not every person is the same. And so with that, thank you. And up for questions. I probably talked more than I thought I was going to, but I typically do that.
No, you're fine. You're fine. I think your conversation definitely sparked a lot of questions. I had a couple comments and questions, but there were a few in the chat that started around the, let's see, that you were talking about Keppra, and I think that, as always, it's like ding, 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 the Keppra conversation comes up. So if you're able to talk a little bit more about that, I think that would be really helpful. Some folks are wondering if there is a possibility of switching, or we always hear about the Keppra rage.
Yeah.
So, are there things that, adults can do to supplement, or even just like, how common is it for people to be taking Keppra and another medication just to kind of counter those side effects? So I
Yeah.
think we'll start with that.
Yeah, I think Keppra is a great medication, but also unfortunate in some extent. Like I think it's very useful. Like when someone is not sure if a patient has focal seizures or generalized seizures, and it's really unknown. It's a broad spectrum. It works for both focal seizures and generalized seizures. However, while you don't have to check labs, and it's well tolerated by the kidneys, it's well tolerated by the liver. There's very low likelihood of rashes. It can cause a rage in about 1 out of 4 or 1 out of 5 patients. I see that someone wrote, I feel like I'm going nuts. You may be, and it may be the medicine. And so while there are things to try, like vitamin B6, like I said, sometimes I try that first, but if it doesn't work, then there are other options. I think there are newer options. And so brivaracetam was a medication that came not long ago to follow Keppra because it works very similarly mechanistically, but it doesn't have the rage side effects. And so it's much better tolerated than Keppra when someone feels like they can't control their mood, or they're too irritable or too sensitive, or they're like, chewing up their family members when they say that they're doing something wrong and they just scream at just their loved ones. And so I don't think that's acceptable. Quality of life, it is important. So I would say you discuss that with your physician and see what other options there are for you, and whether it would be a good time to try something else.
And in terms of like the titration period of Keppra, how much time would you say to someone that, okay, this is not working for you, for your mood, like let's try something else? Like what's that range of time?
So it depends. I've had patients that have become so like that families call within a few days that this is like we can't even hold the child, and so that's enough for me to say, okay, this is not working. If it's a little bit more tolerable, I may give it 2 to 4 weeks. But if you really feel like you've been on this for months and you feel like there's a definite change when you were yourself and you're not yourself, I think it's time to talk about something different.
Okay. And is it just like you said, a conversation with your provider, or do they have to go through another EEG to get that process started
Not
again?
necessarily.
Okay.
I think a conversation with a provider, if you've already had an EEG and you've had an evaluation, we know you have epilepsy, we know why, well, or we don't know why, but we've had the appropriate evaluation. I think that then you should be able to pick another drug or go from there. Yeah.
Great. And I know you can also see the chat, but it looks like CBD has come up a couple of times. So just kind of wondering your thoughts and comments on the addition of CBD. I know that that's not necessarily, one size fits all, and a
Right.
lot of times it's given in conjunction with other medications.
Yeah. So I'll go first. It says here, what do I think about Cynicimide? So I actually think Cynicimide is a pretty reasonable choice. It also is broad spectrum. It's a little better tolerated than topiramate and less side effects, even though they have a very similar side effect profile. We tend to see the side effects a little bit less with Cynicimide, and it can be taken once a day, which is also nice. So some people just take it at night, and that may be enough. So that's nice. But obviously, like everything has side effects. So it depends on the individual and if it's working. The CBD. So we, especially on the pediatric side, we use Epidiolex a lot, which is cannabidiol, which is a prescribed CBD, and it's pure CBD, so it has no THC. It can be beneficial, but it's only allowed, and we can only prescribe it right now in certain types of epilepsies because it's what the FDA approved it for. We've had a few surprises with patients with other types of epilepsies that ended up on it because they had failed like 10 medications. And we were like, we might as well. And we will fight with insurance because we need to try this because we have tried all these other things and they're not surgery candidates. And I've had a few surprises where like patients do really well on it. But a lot of the times it just feels like it's another medication. And obviously you can tell I don't work for any pharma company, but I just, I think that similar to every medication, it also has side effects. Like it can cause diarrhea. It can make you tired. So sometimes people start it at night. So every patient is different. We also have to monitor labs, even if you're not on any other meds. We monitor the liver, we monitor white count, we monitor several things. So I think it's this idea of that because this is natural, it must be better. Unfortunately, there are abused drugs that are also come from plants and are abused and people die from them. So I think that we have to be very cautious, but they can be helpful, but they haven't been proven to be that much more helpful than our typical medications that we use. So it's one more in the list, and it's nice. It may work for some people and not for others, just like many of our medications. THC, I see here that they're asking about mood change for THC. I actually worry that the THC component can cause, it's what causes patients, or what in the abuse drug, it's what causes people hallucinated. It's like or just kind of be high. And so I worry that our patients get high on it, or that when they take it from a dispensary or something, and if they have high levels of THC, if they get more anxious or more, because not everyone responds the same there. And so I'd be cautious with that. Most of my experience is really with the Epidiolex and the prescribed drug. because we're not even allowed to prescribe what's given in the dispensary. That sometimes so the question is that someone is on lamotrigine and clobazam and appetite has decreased, but seizures are finally better. I think when we see things like that, one of the things is making sure that the appetite can be lower, but if you're still in a healthy weight and you're gaining milestones and doing well over time, I think that's something we can watch closely, and it may get better over time. Now, sometimes we do have to say like, oh, maybe we're losing weight, and then we have to consider other things. And there are medications for appetite that are not that don't have a lot of side effects and that are very kind of benign. And sometimes if we need something like that, because we don't want to give the seizure control away, we may have to talk to the main provider, to the primary physician or pediatrician, and kind of compromise and say, what if we start this other supplement to see if we increase our appetite, and we make kind of compromises that way, because weight is important and seizure control is important. So I think we just take all these things into account and try to make the best out of it. Doc is turned off with natural herbs. So I think this is just out of, and obviously I don't know whose doctor this person is, but Tanisha, but I don't think any of us are turned off. I just think that the data is not that great. And I'm almost never opposed that patients want to try other things. I'm happy to try and monitor with you, but I would say that we like to keep in mind too that these things can also have side effects, and that they can make the efficacy of your other medications affected. So for the same reason that, CBD comes from a plant, many things come from plant that are not good either. And so everything has side effects. There are herbs or herbs that can cause bleeding. And so someone goes to the OR and you can't stop the bleeding because the patient didn't tell us that they were taking certain herb. And I think that it is very important to have ongoing communication. Like we are always happy to try anything, because every patient is different, and anything, and sometimes we are surprised, like, oh wow, this worked for you. And I am open-minded in that, sure, we should try it, but we have to do it carefully. And I think that's where we, on our side, we're very evidence-based. And so if we don't have evidence that I don't want a patient spending thousands of dollars in something that has not been proven to really, really, really help. Do you suggest getting a new EEG before switching medications? It depends on the situation. I think that not always you need an EEG. We get EEGs for diagnosis. We get EEGs to capture different types of spells. We get EEGs over time to monitor, to make sure things have not gone worse, to make sure we're not missing seizures. So there are many reasons why we would get EEGs, but we don't always need an EEG to switch medications. For instance, I guess I'll give an example of, if I have a patient that has had the same seizure type for 10 years, and there was an EEG, like maybe we got the last EEG a year ago, and in the last year I've tried a medication and going up on that medication and it doesn't work, I may just go ahead and the seizure type has not changed and nothing else had changed. I may not repeat an EEG. I may just go and transition medications, because I know the patient and I know what we're dealing with. So there may be instances where you will, and there will be others where you don't necessarily need to. Phenobarbital is tough to come off of. And I think that what I tend to do is, when someone has been on it for years, I try to wean once a month to avoid the withdrawal seizures. Because if you wean faster than that, sometimes you can get breakthrough seizures. I don't know how fast you've been weaning, but sometimes I try that just because the chances of getting used to lower and lower levels over time, kind of the chances of being successful are higher. So depending on the medication, we wean faster or lower, and that's true for all of them. And phenobarb is one that I take a long time, especially if you're struggling. So I say, if you found good control on clobazam, sometimes it means you need to, like, maybe clobazam is not enough. So maybe it's that you add a second one in order to finally get off of phenobarb. But it's a tricky question because it is a hard one. But just very, very, very slow. CBD Charlotte Web is no THC. That's right. Yeah, it's just CBD or pure CBD. Epidiolex is the prescribed CBD. Yeah. Thanks. My son is 20, diagnosed with generalized epilepsy. He has chosen to not take any pharmaceuticals. Any advice for a mom with son that refuses? I think that's a hard one. Because now he can make his own decisions, but I think um, I don't know if psychological help. I think it also depends on the seizure types he's having, safety, if he wants to be independent, driving, the risk of having seizures at night or being alone and something terrible happening. I don't know. It's really hard to convince someone that doesn't want to, that refuses treatment, and that must be really hard. But um, maybe working with a therapist or something to really get to the root of why, and then what could be better, and understanding that not all medications are bad and not all medications will give you side effects. I have patients on meds that feel like nothing happened. And so I think there's this like stigma too to having epilepsy, and the stigma to taking medications that we sometimes need to help patients get through.
Dr. Sosa, I'd like to add to that for parents whose children are whether making their own decisions, whether it's about medications or other things. I have a very close friend who's a pediatrician, and she reminds us, that a child's brain isn't fully formed until they're 26. So legally, our children at 18, are adults. But I think as parents, we have to, and from a medical standpoint, we have to really, really think of them and remind them of that, and really, try to, to partner with the kids. I have had friends who have been very reluctant for various treatments. And it's been hard, but I think, kind of pressing on and just trying to support and open the communication. What I've found is, boy, this younger generation is really great at communicating. They have a lot of things that they want to say, and I think they're better than our generation. So if we can kind of pick up on that communication and openness and really have a frank talk with them, I think it's a good idea.
Yeah. No, I think that's a very good point. I think just having more conversations and not being confrontational. I mean, everyone has very important reasons why they want to do or not, or they don't want to do something. But like you said, it's also like you can't be confrontational with an adolescent and tell them like you're not old, because they think they're adults and they are at the top of the world.
Yeah.
And so I think it's a hard conversation to have, but yeah. Are people ever taken off medications if the EEG shows no seizure activity for the past 6 months? Usually not 6 months. Typically, not necessarily the EEG, but I think talking more about seizures in general. So yes, after someone has been seizure free for at least 2 years. Sometimes we do a little bit less depending on how many seizures they've had in their lifetime. Then we consider coming off seizure medications, and we may or may not repeat an EEG at that time. So if your EEG was normal before, there may not be a reason to repeat one. I tend to do, because then I don't like surprises, even though that's not perfect. But I wouldn't say that if someone's been seizure free for 6 months, you would wean off medications. Now, could you wean one of 3 medications? Possibly. There's always room to improve, and there's always room to like kind of optimize medications and maybe decrease the amount of medication if you need to, but maybe coming off completely is too abrupt after only 6 months. Should I get a 7-day EEG in order to better know where these seizures are coming from? I had one in January and didn't have a seizure in the hospital, so they couldn't tell me where it was coming from. I think so. And especially if your doctor has told you that they can't really tell and your EEG was abnormal and we don't really know what we're treating. I think it's a frustrating process when we can't capture seizures over and over again. But I think it's really the only way for us to tell like where something is coming from and what's the best treatment from there, depending on the type of epilepsy you have. But I think it's important. Is there more benefit in increasing the dosage of Keppra to 1,500 twice daily from? There can be for some patients, just their response is just dose dependent. So there can be. I past 1,500, I've gone very few times because I don't think that more and more and more and more is always better, but it could be tried. What do you think of Vimpat? I think Vimpat is really helpful. I also like that it comes in IV, and that when patients are in the hospital and we struggle, some of our medications don't come IV, and this does. And so you don't have to be like, if someone ends up in the hospital, they don't have to be loaded with a medication that's completely different. They can be loaded with the same medication they're on. I think if patients tend to tolerate it really well, you sometimes see dizziness and maybe even blurred vision or headache at higher doses, and that doesn't always go away, so we have to be cautious of that, but it can be very efficacious, and we've used it in generalized and focal seizures. Have I seen, I wonder if you still see much sudden death in epilepsy. So it's incredibly rare, but it happens, unfortunately. And unfortunately, the ways, our goal is always no seizures, no side effects and all that, and obviously quality of life, including this. And I think that we do, I see that someone heard about it in their first appointment. We try to, when we meet patients, we talk about SUDEP most of the time. I may not talk about SUDEP the first time the patient had a seizure, if they don't have a diagnosis of epilepsy. I think it's tricky also to talk about it when someone has seen someone else and you don't know where they are, like, or how much they know. Like, it's an awkward conversation to be the fifth doctor and maybe you've never heard of it. But I think that, but it is in the end what all parents are worried about, and all family members when they hear seizures. Can someone die from a seizure? And I try to say that it's also like when we think about SIDS and sudden infant death syndrome in babies, it's that rare, right? It's something that when the difference is, and I'll talk about that in a second, but when you go to the pediatrician, you have a baby, and everyone goes to the pediatrician to all these happy visits, they always talk about SIDS, and people, for the most part, ignore it. Like, yeah, it's fine. We'll just put the baby back to sleep, or not, because it's not going to happen to me. But I think SUDEP, while it's as rare as that, I think that it's different because you have a diagnosis that makes you at risk for it. And so you know that you're starting at a point where, like, it's just not a normal baby, then it never comes to your head. And we try to, all the things we can do is try to make the best, control seizures as best as possible, and understand the risk factors. So, like, not taking medicine, not having multiple seizures at night, or having big convulsions and things like that at night that may increase your risk. So it's a difficult conversation to have, but I think it's important. Before, medication that its mechanism only treats focal seizures, I would never try in a generalized epilepsy. Could potentially make it worse. So if I tried carbamazepine in a patient with absence seizures, they're going to come in status epilepticus. So I would never try that. But there are many of the newer medications that initially get approved for one seizure type, and they initially get approved as adjunctive therapy, just because that's what you can do in the initial clinical trials. But over time, they get approved as first medication, and they get approved for different types of seizures. So I think that on the pediatric side, we're a little bit more, we tend to do more off-label things because most of the trials are done in adults in the beginning anyway, I think, except for CBD. But so we're a little bit used to start trying things off-label, obviously with a lot of caution, but we've done it. So it's not, everything we do in epilepsy is a little bit different than other worlds or other body systems. Or more than dose that is normally used, such as more than clobazam than normal. Yeah. So I think the highest dose recommended is what the FDA approves. We definitely go higher than that when we believe that a patient is tolerating well, is not having any side effects, and it's being beneficial, then we may go above the recommended doses. And we do that often with many of our medications. And now if we go much higher than that and nothing changes, and there's no benefit, and there's more side effects, and there's no point, you go back down. But we certainly do that, yes, in terms of dosage. These are on our system for a long time. Phenobarbital is an example, like you get rid of it very slowly. Lamotrigine, you get rid of it very slowly. Medications that can be dosed once a day, but there are others that that Keppra you dose twice a day because otherwise it comes out of your system. So if you're off of the medication within a week or two, you should be back to yourself.
Well, thank you again, Dr. Garcia Sosa.
Thank you for having me, and thank you for all the good questions. And yeah, happy to answer anything afterwards if anyone reaches out to you, Aisha. Okay.
Sure. Fabulous. Thank you so much. Have a great night, everyone. We'll see you next month.